Hello, ladies and gentlemen. Welcome back to the discussion of the neuroanatomy of cerebellum. And in this second part, we're going to now discuss about the clinical neuroanatomy of the cerebellum. How is cerebellum associated with, this kind of coordination and the movement that it makes? So to begin with, we'll talk about ataxia. And so ataxia literally means out of order or without order, because the word taxis comes from it means order in Latin, and ataxia means out of or without order or out of order. So it basically means a lack of coordination. When someone has lost the sense of coordination is when we say that someone has got ataxia. So depending on different regions of the cerebellum, the functional region of cerebellum that we have seen, we said we had the vermis here, we had the intermediate zones, and we had the lateral cerebellar hemispheres. So depending on a specific part or the functional part of the cerebellum that is damaged, the individual is going to present with this lack of coordination in a specific muscle groups. And just as a recap, we said if someone has got, we said the vermis was responsible for the coordination of the proximal of the trunk muscles, and the proximal muscles of the limbs. And we said this intermediate zone over here is responsible for the coordination of the distal muscles of the limb. So the distal muscles of the limb are being coordinated by the intermediate zone of the cerebellum. And lastly, the lateral zone was more of motor planning and high cognitive function, or the cognition with association with the cerebral cortex, and that's why we call them the cerebrocerebellum. So a person can lose the sense of coordination, can lose coordination of the body, the trunk, or coordination of the limbs. So we have two types of ataxia according to the functional localization or the functional classification of the cerebellum. We have the trunk ataxia, loss of coordination of the trunk, and this will be due to the damage on the flocculonodular, on the vermis of the cerebellum, the vermis of cerebellum. So if someone got a lesion on the vermis of cerebellum, he or she will present with truncal ataxia and the loss of coordination of the proximal muscles of the limb. The proximal muscles of the limb and the trunk will be affected. But also we have the appendicular ataxia, or ataxia of the limbs. And remember, we have two limbs. We have two types of limbs. You have upper limbs and lower limbs. So if we have a lesion on the specific part of the cerebellum that is associated with coordination of these limbs, we will have limb ataxia. And limb is divided into two components. That we have the proximal limb muscles, and the distal limb muscles. So the proximal limb muscles will be controlled or coordinated by the vermis, and the distal limb muscles will be controlled by the intermediate. So it depends. So that's in general what ataxia is, and these are the clinical features on someone with ataxia. So now let us see symptoms localization, the symptoms localization of the cerebellar diseases, or cerebellar ataxia. So we have seen that we can have a trunk ataxia or limb ataxia, and on trunk ataxia we have said is due to the lesion of the vermis, and limb coordination is due to the lesion on the cerebellar hemisphere. But what side of the cerebellar hemisphere? It will be the ipsilateral side of the cerebellar hemisphere. And why ipsilateral? We have already said because of double decussation of this information that come from cerebellum to control or to coordinate this muscular movement. Then, well, we can have, eye movement disorders, and, eye movement disorder or the vestibular ocular movement, which are controlled by the flocculonodular lobe. So if we have, this kind of example of nystagmus, the movement disorders of the eyes, the region of the cerebellum that is affected is flocculonodular lobe, the flocculonodular lobe. But lastly, we can have, slurred speech due to, can be a lesion due to lesion on a cerebellar hemisphere or the vermis of the cerebellum, cerebellar hemisphere or the vermis of cerebellum. So, do you know also, like, if someone has alcohol intoxication, or someone who drinks alcohol, when they are drunk, they lose the sense of balance. They lose the sense of balance. So this is because alcohol interferes with neurotransmissions in cerebellum. Neurotransmission in cerebellum will be affected by alcohol use. So basically what it does, it inhibits, it has an inhibitory effect on neurotransmission, so it will relay the information, and by doing so that it will affect the movement coordination. So this is why you see drunk people, they lose the sense of balance, and sometimes even they fall down, because they lose this sense of coordination. Why? Because they have used too much alcohol, and this alcohol inhibits neurotransmission of the cerebellum, the structure which is important and specific for coordination of movement. That also explains for why people with alcohol overdose, they have this slurred speech. They had slurred speech because we have seen also that the speech is being controlled by the cerebellar hemisphere and some parts of the vermis. So that is ataxia in general, but we can break it down. Like we said, we have trunk ataxia and limb ataxia. So let's talk a bit about the ataxia of the appendages, or limb ataxia, and for which we have something that is known as Dysdiadochokinesia. Dysdiadochokinesia is one among the ataxia of the limbs. So the Dysdiadochokinesia, basically what it means is the inability of a person to do rapid alternating movement. Rapid or alternating movement is impaired in person with Dysdiadochokinesia. And remember, because we are saying it's ataxia of the appendages, but specifically the distal muscles of the appendages, the distal muscles of the limbs, for that matter, the forearm, the hand, and the leg and feet. So it's no wonder that the region of the brain, the region of the cerebellum that is associated with coordination of this distal movement is the cerebellar, the intermediate parts of the cerebellum, So someone with this Dysdiadochokinesia, we know that it is the intermediate part which is affected in this kind of disorders. So what happens is the person cannot do the rapid alternating movement. For example, the most common usually is pronation supination. So a rapid movement, rapid pronation supination. Okay, and I have a video here which can help you kind of know what's going on. So let's watch it.
Pay attention to the left hand.
Faster. Right side. Make sure you're touching your leg the whole time. Should be a slap, 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 slap. There you go. Good. Other side.
So I think you can see how it ended. Like the girl could initially like do this rapid test, rapid alternating movement, especially on the right side of the right hand side, but on the left hand side she couldn't. I mean, she initially did perform it well, but she later lost that coordination, and that's what happens in a person with dysdiadochokinesia. So that is a positive sign for the dysdiadochokinesia. So the region of the body, the region of the cerebrum that is affected, the region of the cerebellum that is affected is intermediate zone. Is the intermediate zone or the intermediate part of the cerebellum. Now we have two special tests that we use in daily clinical practice to kind of test the coordination of the limbs. So as I've said, you have the upper limbs and lower limbs, and each one can be affected independently of the other. Now, so for the upper limb, to test for the coordination of the upper limb, now remember, now it's because it's a perpendicular limb, and of course the distal muscular groups, we should also keep in mind that the region of the brain, that the region of the cerebellum that is affected will always be the intermediate zone of the cerebellum. So in test number 1, it is known as finger to nose to finger test. Finger to nose to finger test. So you see, this is the patient here, and this is the doctor or the examiner. This is the examiner and this is the patient. So the patient is asked to touch his nose, and then to touch the hand of the examiner, and then the finger of the examiner, and then to bring back his finger to his nose. So this is why it is called the finger to nose to finger test. So assume this is examiner and this is patient. So I'm touching the tip of the finger of the examiner, and then I'm going back to my nose. So the finger to nose to finger to nose to finger to nose test. So in a normal individual with no cerebellar lesion, it is expected that you do this movement correctly. Why? Because even if there would be a discrepancy, the cerebellum would help to kind of fine-tune this movement. But someone with cerebellar lesion now will lose the sense of joint position in space, and then will not be able to touch the finger of the examiner. So he or she can overshoot the finger, or can lose. So that's what happens when someone has got ataxia. So it's also some form of ataxia, but it's ataxia of the appendage or limb ataxia. So this test will help us to to check for the coordination of the upper limb. So it is called the finger to nose to finger test. And we have now for the lower limb. Now, look like here. So when I was a little boy, I used to sometimes close my eyes and trying to eat with eyes closed, and I couldn't miss my mouth, but I didn't know why. But now I understand that was because of the cerebellum, because it helps me to know to locate the position, the joint of my upper limb, and I had to put it appropriately into my mouth, even with the eyes closed. So that's also some form of coordination of the of the upper limb. So, but we specifically use this finger to nose, but we all day-to-day in day-to-day life we use the application. We use the application of limb coordination while we are performing our daily activities. And then we have another test here, which is known as so it's a Heel-to-Shin test. It's a Heel-to-Shin test, and this one tests for the coordination of the lower limb, coordination of the lower limb. So what happens here is that you take the heel of one leg, for example, heel of the right leg, and then you rub against the shin of the left leg. Because you don't have any damage on the cerebellum, you will be able to locate, to touch your shin with your right heel, and also on the other side as well. You can take the heel of the left side, you rub against the shin of the right leg. And because you don't have any kind of disorders in your cerebellum, you will also always be able to rub against it. So this test is better performed when a patient is in a supine position, so as to eliminate the effects of gravity. Someone can do it on standing position, but there will always be an effect of gravity. And remember, most of the patients that come to the clinic, they are old age, and sometimes they might not be able to overcome the effect of gravity. So you might think that they have coordination problems, but in actual sense they don't. So this is why it is performed when someone is lying on bed on supine position. So if someone has cerebellar lesion, means he or she will not be able to rub the heel of one leg against the shin of the other leg. So we have something very, very, very useful clinically, and it's very, very important. That's known as lumbar test. So listen. So when we stand, or when we are walking, or when we maintain our balance, it is because of the three most important sense of modalities of sensation. So we are able to stand, we are able to have a more coordinated movement, because we have information from these three systems. So visual system, vision, proprioception, the location of joint of the body in space, and the vestibular sense, the sense of balance. All these together, they work together to maintain, the posture. So they work together to maintain the posture. So vision, proprioception, and the vestibular sense. Ideally, these three, they work together, but two of them can work together when the other one has a damage or has a problem. For example, if we have a problem with proprioception, these two, the remaining two, the vision and the vestibular sense, will always compensate for the deficit that is made by the missing component, the missing sensation. I don't know if you can follow. Like if you have damage in the vestibular system, these two should be able to compensate for the damage that is for the missing component, which is vestibular sense. So what happens in lumbar testing is someone has got damage either on the proprioception or the vestibular sensation, but the vision and one of these are intact. For example, let's say now the proprioception is gone, so we remain with the vision and the vestibular sensation or the vestibular sense. So these two can help to kind of mimicking the missing component. So they kind of compensate for the missing proprioception. So if someone has mild lesion or loss of proprioception, he or she can maintain his posture when his eyes are open. Why? Because if now we cancel vision, we'll be losing two components of this system, and the deficit will be visible, will be like obvious. Yeah? The deficit will be obvious. So if someone has a mild lesion or mild loss of proprioception, so vision will, together with vestibular sense, will kind of help to mitigate or to alleviate the symptoms of the missing component. So this is to say, if someone has got a mild vision, he or she can still be maintaining his posture, given that his eyes are open. So if he keeps his eyes open, he can always maintain the pressure. But when the lesion is mild, so, but if this someone closes his eyes, means we have lost the proprioception together. The proprioception together with vision are gone. Proprioception together with vision are gone. So we remaining only with vestibular sense, and this is why this person, when he puts his feet together in this way or this one, he will fall. Why? Because we have lost two components of this system that were meant to maintain the posture in space. So look what happens in this old man here.
All right, sir. Can you put your feet together for me? Do you feel steady?
No, I'm having to correct.
Okay. All right, close your eyes for me. Okay, that's.
So do you see what happens with this old man? It's like he had, I am assuming that he had the proprioception loss. So he has remained with the vestibular sense and the vision. And now you are asking him to close eyes, which means to eliminate the sense of vision. So he will remain only with vestibular sense, which is not enough to maintain posture. And this is what is known as the Lombard test. Lombard test is very important in determining, the sense of posture in an individual. Sense of posture in individual. So that's how it is performed. You ask the patient to put the feet together, and then you ask them to close their eyes. So you always have to be by their side in case they fall, as you can see this old man, because if they have loss, they will fall for sure, and you don't want your patient to fall in front of you. So you have to be by your side, by his side, to make sure he doesn't fall. So lastly, now let's see the summary of the cerebellar lesion. So the cerebellar lesion can be remembered by using the mnemonic Danish. Danish is anything that is associated with Denmark. Could be the people from Denmark, the Danes, but could be something that is related to Denmark, maybe the Danish flag or something. Yeah. So from the word Danish, we have the very first one, which is Dysdiadochokinesia, and we've just seen it here that the person cannot do rapid alternating movement on the region affected. And remember, the regions of the cerebellum will always be ipsilateral. The deficit will be ipsilateral. And then A in Danish, A for ataxia. And ataxia is when someone cannot coordinate the movement. And we said Dysdiadochokinesia is some form of ataxia because we have lost the sense of coordination of the specific part which are the upper limbs, the muscles, the proximal and distal muscles of the upper limb. And then N for nystagmus, and nystagmus is this rapid eye movement that are due to some region in the vestibular vestibular ocular movement of the eyes, and it presents with this optokinetic kind of movement. Yeah, I for intentional tremors, and I want you to note the word intentional. Intentional means these people, they want to make some form of movement. So, for example, the man here is trying to like reach to something. He's like stretching his arm to reach to something, but while he's doing so, because there is no like coordination of the movement is there, but the coordination is not there. That's why we have tremor, and this tremor, we say it's intentional because he has intention of reaching to a specific object, but only he couldn't do so because of this the missing component, which is cerebellum. So that is intentional tremor. And then we can see we have the slurred speech, as we have seen, and I think now you can explain the slurred speech in people who are using alcohol. So why do they have slurred speech? And lastly, we have hypotonia, because cerebellum also helps to maintain the tonicity, the muscle tones, the muscle tone, or the so-called the tonicity of the muscle. So hello guys, now I think we can go back to square one. We go back to where we all started, and I think you remember I promised you by the end of the video, of the second part of the video, which is now, then is when you can explain what happens when someone has got a lesion on the cerebellum, on the vermis of the cerebellum. And this is no wonder that all of you can now explain with no problem what happens when someone has got a lesion on the vermis of the cerebellum. But I'm sure now your expertise in deep cerebellar nuclei and their functional classification, functional division, and the what functional parts of the cerebellum are related to these deep cerebellar nuclei and their relationship with the vestibular nuclei, which are not in the cerebellum, but they work at the deep cerebellar nuclei in organization. So but I also know that now you can give this functional classification of the cerebellum, the functional division of the cerebellum, what are the specific region of the cerebellum, what kind of movement coordination do they do and stuff. And the most important thing of all, as you said, is the ipsilaterality of the cerebellum. The ipsilaterality of the cerebellum. I hope you can now relate the double decussation of the cerebellum and the location symptoms, localization of the cerebellum. Symptoms, localization of cerebellum. Hello, so my name is Dr. Kenneth, and here is my email. If you have question, addition, or comment, don't hesitate to write me an email at kennethybaumba@gmail.com, and I'll get back into your email as soon as I get it, and hopefully before 24 hours we get the answers or whatever you have asked. And until next time.